Quick disclaimer before you listen. The World's Okayest Medic Podcast is an educational and commentary platform produced and recorded by me. What we say on here is not endorsed by any of our employers, and we are not speaking on behalf of our employers. Our commentary is our own. Finally, remember to follow your local protocols. All right, it is not Saturday morning coffee talk. It is Friday coffee talk, and I didn't put morning, noon, or night because I don't know when you're going to be listening to it. And actually, not to be a complete fraudster and throw a wrench completely in your day, it's not even Friday right now. It is Thursday morning, around 10:30 here on the East Coast. And I am filming this. I'm going to put this out on Friday because I got a good weekend coming up. At least I hope it's good. I work a princess shift tomorrow, so Friday, from 7 to 3, a little overtime. And then I'm picking up the kids from school, picking up Ashley, and we are going right down to the beach. Not the shore, that's what they say in New Jersey, but we are going to the beach, the Delaware beach, because it is the yearly Christmas parade and Santa crawl. And it has become a yearly tradition. So we'll spend the weekend out of my aunt and uncle's beach place with the family, carousing, having a good time. So I didn't want to, twice in a month, not do a coffee talk and get them out because I get all the hate and angry DMs when I don't put out a coffee talk episode. We are, let's see, a couple of things before we get into the meat and potatoes. I am doing a lot of podcast recording today. I put the Prep Medic episode out earlier this week. Thank you, Sam, for coming on. I am recording here in about an hour and a half with the HEMS panel that I have been talking about. So look, we're going to talk about utilization, some industry standard stuff. Also, you're going to meet a guy named Sal Cortez. He's going to come on the podcast himself and talk about his background. He's got a great background from EMS to law enforcement. He either runs, he manages, he owns. I don't know what the exact word is. He will tell us, but the International School of Tactical Medicine, where I did my tactical EMS training, and I'm wearing the hat. It's a hat back from 2011. But he's going to be on the panel, so he will be new to the podcast. You'll all get to meet him, and I'll get to meet him because I've never actually talked to him. We've just corresponded. Seems like a totally nice guy. Nevertheless, looking forward to the HEMS panel. I also was going to record a HEMS safety episode with Ryan Bolger, who's a flight medic and nurse. He's been on the podcast before a couple of years ago. He was going to come back on, and we were going to talk about some operational safety stuff. That got derailed this week because Ashley's grandmother died, which screwed up the recording time. Phenomenal woman, 95 years old. It was a very, 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 very expected death, but nevertheless, it's sad, and it threw a wrench in our plans to record. So we will find a time and we will re-record that. And I have other stuff coming down the pike. We've been talking about doing an episode with a pilot, and a couple people have reached out to me and they have stories that they would like to talk about. And I do want to talk to some of them because some of the stuff I hear, I'm like, this needs to get out there. That being said, I don't want to overdo the HEMS topic. So I'm not going to bombard everybody with nonstop HEMS content because the vast majority of people that listen to this podcast do not do helicopter EMS, and I don't want them to get tired of it. So I'm going to sprinkle it in the next few months. I don't want the topic to die. I think if I did everything right now and then just stopped, the topic would die. So, and the utilization and safety stuff that we talk about, and we're going to continue to talk about, needs to stay in everyone's mind. It needs not just be a fad. All right, enough rambling. Let's get into it. This week's coffee talk is going to have a cardiology spin. We're going to get back into some clinical Johns. The reason we're going to get back into the clinical stuff is because I have been running, and my friends at my service have been running non-stop AFib RVR calls. I don't know if you're seeing the same thing where you are, but it has been nuts. I have given more Cardizem in the last week than I probably have in the last 8 months. And I don't give a lot of cardizem anymore because rapid AFib tends to be compensatory. Now, back when I was a younger medic, you're trained, you go through ACLS. We all love the HA. But you go through ACLS and you're trained and it's beaten in your head in medic school. You see that AFib with rapid ventricular response. They don't have preload because the heart doesn't get a chance to relax and fill. So you've got to increase the preload by slowing down the heart and giving it time to fill. So you give a drug like cardizem. That tends to be what EMS gives. The hospitals tend to either give a calcium channel blocker or a beta blocker. There's a lot of metoprolol used, it seems like, but I don't work in the hospital. But you give one of those drugs, it slows the heart rate down. The patient probably remains in AFib. It doesn't really convert the rhythm, but it slows the rate down and it gives the heart time to go and relax. And when the heart relaxes during diastole, it fills with blood. And that makes total sense. So you would see a patient in rapid AFib, they'd be uncomfortable. Maybe they have a little myocardial ischemia because you do see those ST segment depressions in that AFib RVR pattern when you do a 12 lead. As I got more and more and more experienced, I started to treat the rhythm less and less and less because I realized that in the vast majority of patients that I was encountering, these were people who already had a history of AFib. Maybe they were like your grandfather, who is always in atrial fibrillation and is on Eliquis. And the AFib is not necessarily the problem. Rather, the AFib is a symptom of another problem, or I should better say a consequence of another underlying problem that is causing an increased heart rate. In essence, they're compensating for something. It could be infection. It could be dehydration. Nevertheless, the body is compensating for a reason, and you knock out that compensation, and the patient's going to get a lot worse. Several months ago, I responded to this guy. I've had him before. He gets UTIs. When he gets UTIs, he gets really sick. He's in his 80s, so I go into his back bedroom. You can smell UTI as soon as you get to the hallway leading up to the bedroom. He's laying in bed. He's got a little bit of altered mental status. He's confused. He is burning hot to the touch. You could crack an egg on his back and fry the egg. And he is in rapid AFib at a rate of like 180, 190. Now, I've had this guy before. I know he's got a history of AFib. I'm not going to treat him with cardizem because I don't want to knock out his compensation. So I give him a fluid bolus. And I'm like, you know what? He's probably dehydrated. He's either in septic shock or finna be in it. So I give him some IV fluids on the way to the hospital. I call the hospital. I give them report, and I'm told by the doctor, who I'm not saying I'm smarter than the doctor. I'm not. But I disagreed with the doctor in this situation. I am told, why are you flooding this guy with fluid? You need to treat that AFib. And I said, he's got kind of a soft pressure now. His pressure is I think it was in the high 90s. And I told the doc, my concern is that he's got this ragingly hot fever. He's got a history of UTIs. I think he's septic. And if I knock out this guy's heart rate, his blood pressure is going to drop. And I'm told, you need to treat the AFib, give 0.25 milligrams per kilogram of cardizem. And I was like, okay, I'm just the paramedic here. I have to do what the doctor says. So I give 0.25 milligrams per kilogram of cardizem to this gentleman. What do you think happened? The gentleman's AFib rate did go down. I think it went down to the 80 to 120 range, if I recall correctly. But along with his heart rate going down, so the number was better on paper, it will look better in the chart, his blood pressure tanked and was now in the high 60s. And I had to give more fluids, and I rolled into the hospital and told the doctor, followed your orders, gave 0.25 milligrams per kilogram of cardizem, and lo and behold, his blood pressure tanked, thus knocking out his compensation. So I thought to myself, I know I didn't go to medical school. I didn't do fellowship. I'm not saying I'm smarter than this particular doctor. I'm really not. I know I sound like a petulant child
But I went to a couple of doctors that I really respect. And I didn't use any names, but I asked these two docs. I'll say who the docs were. It was Bert, who's been on the podcast before with the medical director episode, and I asked Haney. And I didn't tell them which hospital again, which doctor, blah, blah, blah. I didn't want to get into that drama, but I just presented the case and I said, hey, was I wrong? Bert told me honestly what I already knew. He was like, no, that patient was compensating for something. He's like, I'm much more apt to give a fluid bolus to a patient with AFib rather than just go right to cardizem, especially in this guy. I don't remember exactly what he said. I don't want to put words in his mouth, and I'm not going to go back and dig up the text. Haney was much more colorful in describing how the doctor that I consulted with was wrong. Nevertheless, the story is, that was a long-winded rabbit hole, is that I treat far less atrial fibrillation these days because usually it's an old person, they already have a history of AFib, and they're compensating, and I don't want to knock that compensation out. But the last couple of weeks, it hasn't been like that. It has been people who have a history of AFib, who have gone into AFib RVR before. Nothing has been a prodrome leading up to it. They don't have an infection. They don't really, one of them did have chest pain or an anginal equivalent. I'll talk about her in a minute. But they're kind of those patients like my mom who have a history of AFib. I've gone into rapid AFib a million times before. I take meds for it, or I get cardioverted when it happens. And I don't know, I was sitting watching TV and all of a sudden I felt these palpitations and I feel terrible. I know I'm in AFib. You put them on the monitor and lo and behold, they are in a rapid AFib. Those patients, I tend to give cardizem to those patients because it's an AFib problem versus a compensation problem. So I've been giving a lot of cardizem lately. I didn't give cardizem to a guy though yesterday, and he was like this. He's like, I go into AFib all the time. I've been in AFib all night. He was 86 years old and he looked like he was 55. When we stood and pivoted him to the stair chair, it was like I looked up at him and I was like, oh my God, you are a towering, very strong man. He looked great, and he called because he's been in AFib all night and he felt a little bit dizzy. He was like, I know what's going to happen. You're going to give me medications. It's not going to do anything. And then they're going to have to, quote, zap me at the hospital. I said, have you been zapped? He's like, happened 3 weeks ago. And that was the 5th time they've had to do it. I've been ablated a couple times. Nothing seems to work. He's like, I really just need to be cardioverted. And I'm looking at him. I'm like, you look friggin' great. Your heart rate is in the 180s. Your blood pressure is 74 systolic, but you look absolutely fantastic. As long as this guy wasn't moving, as long as he was sitting down, he looked absolutely perfect. He looked extremely healthy. So I gave him a fluid bolus, and his pressure only came up to the 90s. And I didn't want to give him cardizem because cardizem, while it does slow the rate down, cardizem is also a vasodilator. That's why they treat people with hypertension with cardizem. So you do risk causing hypotension with IV cardizem. So I started off by giving the guy a fluid bolus. He came up a little bit. He came up to the 90s. And then he dropped his blood pressure again. But again, he remained completely asymptomatic. He's looking at me and he can tell because I don't have a good poker face. And he was like, what's going on? I was like, your blood pressure is really low. So I confirmed it. And I was like, yeah, your blood pressure is low. How do you feel? He's like, I feel fine. I called the hospital and I didn't get the last doctor that I talked to about the AFib. I said, Doc, I got this guy. He's got a blood pressure in the 70s. He's in AFib at a rate of 180 to 200. He's been cardioverted before. I said, he is absolutely fine sitting on the stretcher. I kind of don't want to give him cardizem because he's already hypotensive. And the doc was like, no, I wouldn't give him cardizem with that blood pressure. I said, on paper, this guy needs to be cardioverted, but I want to emphasize how well this guy looks. And the doc was like, yeah, you said you started a second fluid bolus. Just keep giving that fluid bolus and don't cardiovert him. I'll check him out when you arrive. And when we arrived, the doc was like, I see what you mean. This guy looks absolutely amazing. The ubiquitous Seek expert consultation case. The introductory case, though, and this is going to bring me into a little added discussion with wide complex tachycardia, bringing that into the mix, is Sunday morning, I worked Saturday night. Sunday morning, I got a shift change call. Of course, it's in the completely far end of the district, so definitely going to be getting out late on this one. It was an 89-year-old female with chest pain. You walk into her house. She looks like she's having the big one. Her lips are blue. She's pale, sweaty, very, very sweet lady. She told me she woke up, no chest pain, but pain in her teeth. A 90-year-old lady with teeth pain and pallor and diaphoresis. That is a cardiac event all day. She's got a very thready pulse. Her blood pressure was 87 systolic, and pop her on the monitor, and I see this beautiful, ugly, wide complex tachycardia. And I thought, holy shit, she's in VTach. Now, again, this is a patient you would think I need to cardiovert this person right now. And on paper, you do. But she was sitting there, sweet as can be, no respiratory distress. Yes, she had a little bit of low blood pressure. Yes, she was pale. Yes, she had VTach. But I was kind of at a conundrum. I was like, what do I do? So I also was thinking, because she told me she has a history of AFib and she's been hospitalized for AFib before, I started going down the pathway of, is this VTach? It sure as fuck looks like it on the monitor. Or is this AFib and she's got a 90-year-old heart? She probably has a left bundle branch block. Is this AFib, rapid ventricular response with aberrant conduction? And I didn't know. But what I did decide right there, and you can criticize my decision. We can Monday morning quarterback all the time. I accept critiques. I didn't cardiovert her because I'm like, you look pale, you got a low blood pressure, you got this ugly, wide, complex tachycardia. But I made a command decision on scene. I very easily got an IV on her. I'm going to try some meds first and see what happens. So the day shift medic really did me a solid. He heard the call go out on his way to work. And he was like, Mike's really going to get out late. So he met me on scene and we switched out. So thank you, Mike, for doing that. That was rock solid of you. But I had Mike with me on scene, and Mike's a great medic. And we were both looking at this 12 lead and at the rhythm strip. And we're like, this really, really looks like VTach. We're actually going to do this episode. We're going to record an episode where we do this case study because it kind of was, we really have been nerding out on this EKG. But right there in the ladies' living room is not the time to be nerding out on this EKG. I was thinking this looks like VTach. This sounds like VTach. This quacks like a duck. The duck's name is VTach, but she does have this AFib history. She's older than dirt, so she probably does have an intraventricular conduction delay. And then I thought to myself, Mike, you are on this podcast all the time harping that 80% of wide complex tachycardia is VTach. If they have a cardiac history, the positive predictive value of that wide complex tachycardia being VTach is greater than 95%. Don't overthink things. It is VTach until proven otherwise. So we made the decision. We're treating her like she has VTach. So we decided we're going to follow our protocol and we're going to give her amiodarone. And if we end up being wrong and it's not VTach and it is AFib with aberrant conduction, fuck it, because amio works on everything. So amiodarone, she got, it did slow her rate down and you could see underlying AFib. And I thought, all right, it wasn't VTach, it was AFib. But then Mike and I were talking, we were looking at the EKG and we were like, God, it really does look like VTach. What could it be? And like 80% of all wide complex tachycardias are VTach. I did nerd out and I did some research, and I'm going to bring up a paper that I cited because I thought to myself, as much as the EKG looked like VTach, the fact that she had underlying AFib once she got amiodarone and her rate slowed down. And by the way, her pressure got absolutely fine. And Mike said she looked like $1 million by the time she got to the hospital without being cardioverted. Who wants to cardiovert a nice little old lady in her living room? Not me. And do you sedate her? Anyway. So I thought, well, this is the smoking gun, the fact that it was AFib once she slowed down. So I started going down PubMed rabbit holes, and maybe not so much. Granted, this is just one paper, citation in the show notes, Kim et al. From 2021. And it said that even if they are in AFib or have a history of AFib, it very well may be VTAC. You can read the paper yourself. It's kind of a long paper. It is very technical. It wasn't the easiest of papers to read. I'll put it that way. I had to do some highlighting and some annotation. And again, we'll talk about it later. But the one thing that I wanted to bring up, and this is a quote from the paper, is that they said basically, the way I interpreted it is that there can be a disconnection problem between the atria and the ventricles, or an abnormal conduction problem in some patients that can trigger VTAC if the patient is in AFib. So I'll read what they said. I recommend you read the paper, and we'll move on. They write, it is possible that rapid ventricular activation by AFib might create conditions that enable the occurrence of ventricular arrhythmias. Under high adrenergic activation situations, such as physical exercise, atrioventricular delay, and atrioventricular nodal effective refractive period can progressively shorten, allowing rapid activation of ventricles and possibly the R on T phenomenon. Prior study actually reported R on T phenomenon in AFib patients, which was recorded in implantable cardioverter defibrillator, suggesting that AFib can be an atypical trigger of lethal ventricular arrhythmias, even in patients without pre-excitation. So there you go. Again, clear as mud. So along with this theme of AFib, so timing always seems to kind of align for some reason. And with this AFib theme and with the wide complex tachycardia stuff, I did a reel over the summer where I presented a case with wide complex tachycardia. And I said, oh my God, why, when you have a regular wide complex tachycardia, is everybody trying to talk you out of that is actually ventricular tachycardia? And I don't know what happened. Maybe other people are having wide complex tach patients and they're searching for stuff, but that reel has re-hit the algorithm and it's been getting a lot more likes, a lot more traction. And with that comes a lot of comments. And a couple of comments stuck out. I'm going to read two of them. And this is where, if you noticed from me talking about these cases, I wasn't totally sure of myself with how to manage these patients. Now, granted, I made the definitive decision and I think treated them very appropriately, but it always makes me kind of, when somebody is so cocksure about something. So, all right, I'm just going to read the comments. One was, where is it? I lost it here. Okay. There is a distinct difference and potential treatment if you don't know how to recognize it. Example, giving amiodarone to a patient you think is in VTAC because you failed to recognize it as aberrant AFib or SVT with WPW will have a, quote, emphasize, very high chance of killing your patient. And I thought it was like that meme where the guy's like, are you sure about that? Are you really sure about that? Now, indeed, I have heard before that giving amiodarone to a patient with Wolff-Parkinson-White can trigger ventricular fibrillation. We've all heard that with verapamil also. But I had to ask myself, is this really a thing? Because I may have heard that about amio before. I'm pretty sure I had, but I was also thinking, I don't know of any protocols, certainly not in mine, where if the patient has a history of Wolff-Parkinson-White, giving amiodarone is contraindicated. So I went looking because I wanted to confirm this very high chance of killing your patient if you give them amiodarone if they have Wolff-Parkinson-White. And first off, this is a great example of if you hear hoofbeats, think horses, not zebras. First off, yeah, if they have a delta wave or that slurred wave, then yeah, think Wolff-Parkinson-White. But the incidence of Wolff-Parkinson-White in human beings is 0.1 to 0.5%. So if you have a patient with wide complex tachycardia and they don't scream, hey, I have Wolff-Parkinson-White, I'm not sure if I would withhold an appropriate medication because it might cause a problem if they maybe have this issue that 0.1 to 0.5% of the population have. The second thing is that amio for years has been a treatment for tachycardia in patients who have Wolff-Parkinson-White. You can go on PubMed and look that up. But indeed, there is some stuff, to use an academic term, that amiodarone IV may precipitate ventricular fibrillation in the patient with WPW. And it is gold standard academic stuff, people. I found one 1996 paper that did describe it. And then I found a case study from 1987. I'm sure there's more stuff. I didn't do like a 3-hour deep dive into PubMed, but I did find that, yeah, you can give amiodarone to a patient with Wolff-Parkinson-White. And yes, there have been cases described where the patient goes into VFib, but the incidence is very, very small. I will cite one more recent study that I found. Granted, this was not a perfect study. It was a small sample size. It was retrospective, blah, 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 blah. It was Ren et al. 2021 from the Journal of Pacing Clinical Electrophysiology. They looked at giving amiodarone IV in Wolff-Parkinson-White and AFib for tachycardia. There was no ventricular acceleration or VFib that was suffered by the patients. The patients had a 3.3% incidence of hypotension. 60% of them converted to a normal sinus rhythm. And the conclusion was that intravenous amiodarone might be a choice for treatment of AFib and Wolff-Parkinson-White. So just, I get it. I appreciated the comment, but I was thinking, like, are you just regurgitating information that you found and you're now you have a very high chance of killing your patient? No. The next comment that I didn't really know how to interpret this comment. It said 60% of wide complex tachycardias with a pulse are AVRT, atrioventricular reciprocating tachycardia. I'm not going to go into it. Look it up. Life in the Fast Lane is my go-to reference for things like this. But all right, 60% of wide complex tachycardia with a pulse are AVRT. It doesn't matter. Treatment is still the same, which is correct. The pursuit of knowledge in a very oversimplified world is something to encourage, not flaunter. I don't know what he was going at with that. I don't know if he was trying to say keep it simple, or if he was saying that maybe we should consider that things are more complex than they seem and that we shouldn't encourage people just saying, well, just keep things simple. These are complex things to think about, and you do need to know your shit. You do need to think about these complex things. You also do need to remember that with more complex knowledge can come more analysis paralysis. You know, I'm not saying like, hey, it's wide, fuck it, just zap it. No, I'm saying think things through, but also realize that despite all of these fancy things, if it is a wide complex tachycardia and it's regular, it really probably is VTach. So I wanted to look up this 60% of wide complex tachycardia with the pulse or AVRT. I couldn't find that. I found some stuff that showed a very low incidence of wide complex tachycardia with the pulse being AVRT. I didn't cite them, but I couldn't find anything that says 60% of wide complex tach. Maybe I was looking in the wrong places. I don't know. It does make me think, though, the comment of that famous Abraham Lincoln quote that 13% of all statistics are made up on the spot. Think that one over. So I did go looking very briefly at some AVRTs causing wide complex tachycardia stuff. So I went to my go-to quick reference, Life in the Fast Lane, and it said, this rhythm can be difficult to distinguish from VT. And if there is any doubt, we should presume a diagnosis of VT and treat accordingly. So there you go. And like I said, I went down PubMed. I was looking to see if I could find this 60% of wide complex tachycardia. So I couldn't. So what did I do? I did what most, I shouldn't say most, but what a lot of EMS content creators do. And I went to ChatGPT. Actually, I don't use ChatGPT. I use Google Gemini, and I pay for a good version of Google Gemini. And that's how I do all of my content. I'm totally kidding. I'm totally kidding. There is a lot of AI content out there, though. Anytime you see lots of lists What I see people do, now I'm getting off topic, but what I see people do is they say, oh, I don't use AI. I write my own content. What I see people do is they'll type in that question and ChatGPT or Gemini or Grok, whatever you use, will spit out a whole long list of stuff with lots of bullet points. And I see those bullet points written in people's blogs. So what they'll do is it'll be 90% what AI spit out, and then they'll add a little sentence or a little comment. So when people are like, I love writing blogs, I wrote a blog on this, it's like, no, you wrote 2 sentences into something that you cut and pasted. Anyway, so to answer this AVRT thing, I did go to Google Gemini and I typed in what percentage of wide complex tachycardia with a pulse is AVRT. And here's what I got back. Without all the bullet points, it said the incidence of atrioventricular reciprocating tachycardia with a wide QRS complex is not precisely documented, but it is known to occur in a minority of AVRT cases, specifically in the form of an antidromic AVRT. The pre-hospitalist did some content on this, I think. This type of AVRT accounts for a smaller percentage of all AVRTs compared to its narrow complex counterpart. Orthodromic AVRT, wide complex tachycardia, is most commonly caused by ventricular tachycardia, which can make distinguishing the cause challenging. So AI told me what I already know with a lot of verbosity. I really don't know if I have anything else to talk about on this coffee talk, because that's been my week. Wide complex and narrow complex tachycardia and AFib. I may do some content on this later. I've been talking to some people. This is completely switching gears. Let's talk about the mental health thing real quick, because somebody reached out to me with some stuff, and the general gist was that I kind of, in nice and understanding, but very direct terms, told the person, you need to get your fucking shit together. You see a lot of the mental health content stuff on the social medias, at least in the first responder world, which is great. It is okay not to be okay. I'm very upfront that I had some very bad years. Anybody who's consistently listened to the podcast know that my mid-30s were a very turbulent time, a lot of bad life choices, a lot of depression, some dark times, but, you know, a lot of hard work and a lot of help. I got out of it, and I'm pretty good. So it is good to see all that understanding first responder mental health stuff and break the stigma. And you see that quote that's all the time. It is okay not to be okay. And I'm glad that that's out there. I want to add my little spin to it, though. And I'm not a psychologist. I'm not a professional. I am not one of these people who thinks that just because I had my own struggles in the past, that makes me an expert. No, those people drive me nuts. I've also had a cavity before. I've had a very bad toothache. That doesn't qualify me to be a dentist because I've experienced that. But I kind of put my own spin on it when I talked to this person, and I was like, it's okay not to be okay, but it is not okay to stay like that. You need to have some resiliency. You need to get out of the hole. And the only person that can get out of that hole is you. You can go to the best doctor in the world. You could take the best meds in the world, the best meds that money can buy, that your crappy healthcare plan as a first responder allows you to get. I don't agree with that, the old paradigm that if you had any mental health problems, it should be drummed out of the profession. But as one close friend and content creator who I was talking to about this, he said, you know, you used to have one breakdown and you'd be drummed out of the profession, but now you have a breakdown and it's celebrated, and that's not okay. So we need to be understanding with the whole mental health thing. We need to make it a welcoming and encouraging environment for people to seek help if they have problems. But you got to do the work if you're the one having problems. It is your friggin' responsibility. There was a guy who I was professionally associated with as a paramedic. I didn't work with him on the line as a paramedic, but I knew him. We were in the same circle. He did some really dumb shit and got in trouble. And he was indeed going through a very dark time in life. And he was like, oh my God, my mental health problems, I broke my sobriety, all this stuff, which is indeed true. And, please get help. We'll point you in the right direction. But I was like, this is your responsibility. Yes, we need to be supportive as peers. We need to genuinely hope that he gets himself correct, but it's himself that needs to get correct. The mental health is his responsibility. It's not everybody else's. So while I don't think you should be drummed out of the profession, or I'm not saying like, oh, you need, like, you shouldn't be in this job. I don't agree with that. I saw another content creator it wasn't EMS, it was another flavor of first responders talk about basically how therapy's for pussies. And I was thinking to myself when I watched this, I was like, people are going to lose their shit. I definitely don't agree with this. And I thought to myself, this is somebody who doesn't realize it, but they are mentally ill and they are probably going through a very, very bad lifetime. And I kind of felt pity for that person. And I was right. They disappeared for a while and they came back and they were like, hey, I went through some bad times, blah, blah, blah. So we need to be very supportive. We need to promote good mental health medicine and psychology and seeking help using professionals. But we also need to promote accountability. And if you are going through some mental health shit, and I say this from experience, it's not everyone else's problem. It is your problem. We want you to get better, but it's on you, and you need to be the one to get your shit together. Boom. With that, that's the coffee talk. I hope you all have a great weekend. I will be thinking about you while I am carousing around the starboard in red and green and being all festive as fuck, as the young people say. So talk to you this week. Look for the content that's coming out with the hem stuff. That's what I got. See y'all.